Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Hi, everybody. I'm going to be talking with you today about our pharmacist-physician collaboration and how to add a pharmacist to your primary care team. And this presentation is a collaboration between the Tennessee Heart Health Network and the Tennessee American Academy of Family Physicians. And CE will be provided by both the TNAFP as well as UT College of Pharmacy. Our disclosures, there's no commercial support for this CME activity, and I have no financial relationships with anyone that has to do with this CE activity. Okay, so as we get started, I am going to paint a picture for you of what it would be like to have a pharmacist as part of a primary care practice. So it's really important to think about where everybody is in the audience. Some people may already be working with a pharmacist in their clinic. Some people may not even be able to think about that. They may kind of think, what would a pharmacist do? I do feel like this is becoming more and more popular and more people are asking about it. So as we go through the presentation, I'd like for you to take some time and really imagine your own practice and imagine areas of improvement and see if we can broaden our scope and our vision of what a pharmacist could bring to the table. Our learning objectives will be to look for quality opportunities that could be improved by implementing pharmacist clinical services. We're also going to look at specific codes for patient populations that could support sustainable clinical pharmacy services to make sure that we can retain our staff once we've hired a clinical pharmacist. And then we want to review networking and clinic audit practices that may indicate areas for clinical pharmacy intervention and implementation. So to start with, as we were talking about with painting that picture, I asked a few of our fearless leaders to share with us who are already working with clinical pharmacists. Based on your experience, what do you think a pharmacist brings to the table? What do you think what are the benefits of having a pharmacist on your team? Dr. Jim Bailey, who many of you are familiar with, and working with the Tennessee Heart Health Network, shared with us that having a pharmacist extends our team and our capacity to provide high-quality care. Working side by side with a pharmacist helps you to quickly identify and address medication issues, improve adherence, and reduce problems related to drug interactions and side effects. And a pharmacist can assist with routine adjustment of medications to help patients more rapidly get to control for conditions like hypertension and diabetes. So not only is Dr. Bailey the executive director for the Tennessee Heart Health Network and Population Health Consortium, but he's also an internal medicine physician with Regional 1. We asked Dr. Pam Singer with the Ascension Medical Group, and she said the benefit of collaboration with PharmDs in a primary care practice cannot be overstated. I love that. So she said, having worked with PharmDs in the family medicine program, I know firsthand that in chronic disease states, PharmDs excel in adding education, follow-up, in management in COPD, diabetes, Coumadin management, and CHF, just to name a few. In a busy practice where chronic care is the source of revenue for most physicians, PharmDs add value by managing and charging for visits that require medication review, follow-up of diabetes management goals, and education on the use of devices related to diabetes care, COPD, and at-home monitoring of the Coumadin products. So depending on the practice, PharmDs can also help maintain a high bar that are required for quality measures. And team care roles, there are no better team players than PharmDs. So she was really singing the praises there from Ascension Medical Group. At Ballad Health, there is integration of pharmacy technicians as well as pharmacists, and a lot of these have been hired from the community pharmacy setting. So Dr. Megan Johnson kind of spoke about this. She said the knowledge and guidance that the pharmacy team offers is priceless. It's a huge benefit in providing the best possible care for our patients. Personally, it's a huge asset to my workload. Your team helps answer questions that would take much more time for me to research on my own and provide expertise that I would not have elsewhere. The pharmacy tech is a huge benefit also in getting PAs approved and for the patients in a timely manner. This helps take work off the nurses. Plus, Ashley, she's one of the pharmacy technicians, helps to identify covered medications and medication availability. And she says she could go on and on about how much the pharmacy team helps to provide care for our patients and makes the job easier. I utilize you all in every day and would be lost without you. And lastly, we have Dr. Brandon Todd from Christ Community Health Services, who said clinical pharmacists are indispensable to a patient-centered medical team. They serve many critical roles, including those related to medication safety and patient education. They truly enhance the practice of medicine. So we've got really their 4 strong advocates that are all physicians working in practice right now, who have pharmacists working with them side by side as part of the team. So let's talk about some of the evidence that's out there. Some of the most pressing evidence and newest evidence is showing how much pharmacists can make a difference in quality metrics. So star ratings were introduced in 2007, and they help to evaluate the Part D Medicare plans. And they include a maximum of 9 domains and 40 measures. So the measures are assigned a weight of 1, 2, 3, or 5. So 1 is poor performance, 3 is average performance, and 5 is excellent. So that's pretty self-evident there. But when plans perform better, there are a lot of benefits that they get. So they can enroll patients year-round, so that increases the number of beneficiaries they have, and increases their revenue, and increases the way that they can manage risk, and their reimbursement is better. And then the providers also benefit financially because they give providers incentives. On the pharmacy side, that would be things like preferred network status and things like that, and patients can have things like lower copays at their pharmacies. So approximately 50% of CMS star rating quality measures can be directly impacted by pharmacists. So the ones that affect in the clinic setting, outpatient setting, would be things like medication adherence. It's a triple weighted measure. So oral antidiabetics are a huge one. So if you think everything that's not injectable that we use to treat diabetes, the RAS inhibitors, antihypertensives, so things like ACE inhibitors or ARBs, because we're trying to prevent kidney damage that can occur and is preventable with diabetes, and then statin use and adherence with that one. That one can be a tricky one. And also just the use of it in general. If someone has a diagnosis of diabetes, making sure that they are using that to help prevent heart attack and stroke. And then A1C itself, A1C control is triple weighted. Then we have preventative screenings, that list itself is long, and vaccinations. So pharmacist interventions for diabetes and quality. This study was conducted in 2021 in a hospital-based ambulatory care center. So this would be something similar to what we mentioned before, like Regional 1 outpatient clinic. So there were clinical pharmacists, and they partnered with 8 primary care providers, so a fairly large practice there. And they targeted CMS star ratings via a collaborative practice agreement. So in the state of Tennessee, we can also practice via a collaborative practice agreement, which allows pharmacists to initiate, start, and stop medications for patients when needed within a certain scope. So in this case, it had to do with diabetes. So there were 176 interventions here that you can see in the pie chart. And then if you look at figure 2, you can see the quality measures that are satisfied. So it's really interesting to kind of read through there. So the DO8 bar there is medication adherence for diabetes medications. And so that would be the oral ones we just talked about. And you can see it's at 100%. That's pretty incredible. The RAS antagonists are at 100%. The statins are at 100%. Again, those are incredible numbers. D12 is statin use in persons with diabetes. So that means somebody that has been diagnosed is also prescribed the statin that we just talked about. So that's at 53%. And that, again, is another one that's a little bit tricky because sometimes we have patients that say that they have had side effects or adverse effects with statins in the past, have tried several, and that's something that we can work with patients on or look at alternatives. The CO3 is the annual flu vaccine, and they're at 73.7%, that's a great number, certainly higher than some of the numbers that we are seeing right now in the state of Tennessee. The diabetes eye care exam, CO9, is at 100%. Also incredible. Kidney disease monitoring, meaning that we're checking creatinine clearance for the patients at least once a year, doing really good there at 75.7. And then C11 is 87.5, and that's the A1C number, meaning that it is below 8%. So 87.5% of the Medicare patients there have an A1C below 8. And the average A1C reduction of the patients who were in this pilot study was 3.74%. And, if you follow any of the new medications on the market as they're introduced, that number is phenomenal in working with these patients. So as you can see, this is just one example, but there's ample evidence of pharmacists having a very impactful change with patients quickly. An A1C change, we can do that very quickly. We can have a long-term effect as well on quality, which can then translate to revenue. Okay, so as we're thinking about how pharmacists can impact our practice, we do have to think about whether we're living paycheck to paycheck or whether we're planning for longevity. So paycheck to paycheck is what we refer to as the fee-for-service model, and that is what we have lived in for so long. And a lot of our clinics, we do have to be in that model because we do have to pay the bills that are due every single month or payroll that's due every 2 weeks. But unfortunately, our quality metrics and our MIP scores and things like that, quality reporting and the revenue that's tied to it is something that we can no longer afford to ignore. So when I was working in kind of account management and primary care, I would have clinics several years ago that would say, when I look at my MIPS data, I'm losing out on, about $68,000, $70,000 a year. It would take about that much for me to hire someone and to fix these numbers. So I'm okay with losing it. However, I would encourage you to think about that money is money that you are entitled to because you billed and did that work for Medicare beneficiaries. And Medicare payments can depend on the physician score in 4 areas, so they can adjust up or down up to 9%. So that's quality, resource use, clinical practice improvement activities, and then meaningful use of the EHR. And then physicians who score extremely high will be eligible for bonus payments up to 27%. So that is a huge, huge ability for physicians to be able to increase revenue by doing the work that they already doing and doing it well to benefit the patients. What the evidence shows us is that the system for tracking and reporting, because of the time that it takes and because of the denominator, can disproportionately penalize smaller practices despite having really good performances. So I'm going to give you an example in this CE today called Tennessee County Medical Clinic. It's a fictional clinic, but I do want to let you kind of picture it in your head and make it easy. So it's Tennessee County Medical Clinic, TCMC, and they're privately owned. They're fee for service. We have the owners are Dr. Sandra Harris and Dr. Deepti Singh. So they're both the CEO and COO, clinician and owner, both of them. We have a CPA who is the CFO. We have an RN nursing manager, and we have an FTE billing manager. So 9 providers in the practice total. We have an ultrasound tech in-house, 2 lab techs, 15 nurses who are MAs or LPNs, and then we've got 8 people who are running the front desk or admin employees. Okay. So this clinic is thinking about integrating a clinical pharmacist, and they're going to use their EHR to assess individual patient data in areas of concern. So if you were to do this, you could go to the person in your clinic who is a super user. You could go to your IT company that you use or department. You could work with your individual payers because sometimes they will give you reports about all the way down to certain patients and utilization in areas that you need to work on, your ACO, or you can use your EHR. So when I first started working in primary care as a clinical pharmacist, we used our EHR to generate these reports for ourselves to kind of just give us a bigger picture if this was an area we even needed to work on. So for diabetes care, we would run a report and see how many patients do we have in the last 12 months with an A1C above 8, and then how many of those are Medicare beneficiaries. In that case, it gave us about 250. You can also run a report and see how many patients with any of the diagnoses of diabetes are Medicare beneficiaries. And then in your community, if you have diabetes self-management education going on already, which a lot of us do not, if you look at the accredited programs across the state, then most likely those patients are eligible for DSME billing codes. And we'll talk about that in just a minute. Medication management adherence, so we can look up above 18, above 65 with asthma, antidepressant and anti-anxiety medication use. And diagnosis, we can look at diabetes oral medication, so we can pull those by specific utilization. Statin use, we can look up those with Coumadin use, and so on and so forth as we go through here. And that'll kind of give us the pool and also help us to estimate maybe how much time that we would need for the pharmacist. So in this part, we can discuss what areas from the previous list have you had difficulty implementing with consistency or operationalizing for the physicians. And for the pharmacist, we can discuss examples of clinical pharmacist interventions. What areas have you had success? So the responses that I have, physicians, are that it can be hard to know where patients get their flu shots. And you're right about that, because the way that question is worded can make a big difference, but it does count towards your quality metrics if they get their flu shot at the pharmacy, if they get it at maybe the senior center or somewhere else. As long as they get the flu shot, it counts for your quality metrics. But how do we make sure that they answer that in triage or wherever else they answer it and make sure that you get credit for it? The other answer that I have is it's difficult to measure when patients are adherent to their medications. Yes, and that's a great opportunity to partner with community pharmacies, to partner for synchronization programs, packaging programs, and things like that, especially for those patients who are on a lot of different chronic medications, because that's where it can get really tricky. Okay. And for the pharmacist question, I have, let's see here. I have the answers of medication optimization for overall hypertension control. I've been really successful. I've been able to see changes. I've been working in the diabetes areas with patients and we've had success. And then I've seen success in lowering A1C with CGM devices. So another great way that pharmacists can be helpful is to navigate the insurance coverage of CGM devices or other things like that that are newer or maybe more effective, but sometimes aren't prescribed to the maximum availability because they're expensive and we're afraid that the patient wouldn't be able to pay for them out of pocket. But if with more work, sometimes they can be. So now I'm going to talk to you about some of those. When we go back to the amount, we've got to pay for the pharmacist time and this employee right now. But we also need to think about long-term sustainability, how we can do that. The annual wellness visit is a great way to do it. It pays at a higher rate and is also compatible with ancillary codes that can be added to it. It can be done on the same day as a refill visit. And it's a great time for the pharmacist to get to know your reliable patients you've had a long-term relationship with. So this is an example of a workflow where an MA, for instance, triages a patient that are scheduled for the refill visit. The pharmacist conducts the medication reconciliation, health risk assessment, creates a care plan. And then in the midst of that conversation, we can see if the patient is eligible for remote patient monitoring, diabetes prevention program, diabetes self-management education, chronic care management, or a pharmacist visit. And then after that, the PA or nurse practitioner or physician would come in and complete the exam and write refills. But during the course of this visit and doing the health risk assessment and all of the screenings, the pharmacist kind of gets to know the patient and can identify these other programs that last, potentially the next 12 months and are also revenue opportunities that can optimize quality scores as well. I always kind of say the annual wellness visit is the Swiss Army knife of visit types because it can refer to these other revenue opportunities. But the reason why we are referring is to help control another type of chronic disease. The reason why we would refer to diabetes prevention program is to control fasting blood glucose, weight, exercise, and A1C. The reason why we would refer to chronic care management is because people have 2 or more chronic conditions and they require more care and more time and communication from our team. We already do that and we should be reimbursed for that time and so on. That's as these go through. And as we do that work, we will help them to achieve better outcomes. I share this slide, and some people may already know how to do this, but some people may not. So if you click on this link, Palmetto is our MAC, which administers our Medicare system for the state of Tennessee. If you're in a different state, you may have a different one. So you can look up your state and then MAC, and it should give you what your MAC is. So when you look up your physician fee schedule, you'll want to change it to the year. So for us, it would be 2024 there, and leave the selection type display fees for up to 5 procedure codes is what I usually do. If I'm looking up more than one, you want to make sure you have your state selected. For us, it would be Tennessee, but there's several other states that Palmetto administers. And then we would type in whichever code we're kind of looking up. The reimbursement fee is the participating fee there. As long as you're contracted with Medicare, that's what that is. The limiting charge is how much you can submit and the effective date. It's important to stay up to date on these. They do tend to change a little bit from year to year, and sometimes they can change within the year. So if you can kind of stay up to date on these, it can help you to project how many patients and how much is possible to be made from each of the codes or from a certain type of service you're trying to start. I'm going to give you another example from a diabetes workflow. So what you can do is take a patient, let's say a Medicare beneficiary with an elevated A1C you identify from the EHR. Then we could schedule them with a mid-level practitioner or PharmD. You can discuss all of this with the annual wellness visit, as we talked about before, and then present and enroll them with RPM with a glucometer. In this particular example, I do have a vendor administering the RPM, but if you wanted to do that in-house, that's also an option. The vendor, of course, would take part of the money revenue from administering the RPM. If you did it in-house, you would keep all of it, but you would also have to keep up with the devices and the platform and that type of thing. So that would be a trade-off that we could discuss if you're interested. So then after the RPM is rolling and the patient is using, in this case, would be using the glucometer and we're getting readings, the pharmacist could then reach out for out-of-range readings, whether they're too high or too low. So let's say this patient was presenting with an A1C above 9. The pharmacist then could reach out and adjust medications. If they were newly starting insulin, they could help them to achieve blood glucose results because, as we know, the package insert dosing instructions requires that dose to be adjusted every 3 days until fasting blood glucose is below 120. So you're adjusting it by 2 to 3 units. This is a complicated dosing schedule for patients, especially if they've never injected themselves. And typically this is something that we just don't have time to call patients every 3 days or to try to give them a list of instructions. We talk about literacy levels, health literacy levels, and expect patients to go home and remember this. And so if we're not having this more consistent and in-between appointments interaction, it can be difficult for them to achieve that and then for us to see a difference in the A1C by the next visit. So that allows us to do it and to be paid for our time. We can also add in DSME or the diabetes education so that lifestyle, food, exercise, family, complications, all of those things can be addressed. And we can have return visits with the pharmacist every 3 months or mid-level. And then we can evaluate the quality metric achievement annually as well as A1C every 3 months so that we know they're on the right track. So that would be a workflow that we would have fee-for-service payments as well as the intention of improved quality metrics. This is an example of an at-capacity PharmD workflow and different codes that you could use. I really use the obesity counseling code as my bread and butter when I worked in primary care in my first kind of full-time position there, because patients with a BMI over 30 were eligible for this code 22 visits a year. If they did not achieve a BMI in the normal range, they were eligible to have those 22 visits again in the following calendar year. Very similar with smoking cessation, patients are eligible for 2 quit attempts per calendar year, and they can try again the following year. We talked about the eligibility for DSME. Patients who have never accessed that benefit before have 10 hours of education, and then they have 2 hours of individual education every year after that. And then the CVD education, patients are entitled to 1 appointment per year. And the DPP group is a fasting blood glucose between 100 and 120 and an A1C of 5.7 to 6.4. So that includes a lot of people. And you can kind of work with your worksheet and your payer makeup and what your show rate is like and that type of thing, and start to estimate what we think the reimbursement would be, how many people you think you could enroll and have more than 1 visit and things like that. So there's a few notes on supervision requirements, which is also a great place to start when you're thinking about what codes you want to implement. So collaborative practice agreements, we talked about that, which define the scope of practice. They don't guarantee that you will be paid, but they are required for contracting and credentialing. So in the state of Tennessee, pharmacists are defined as providers, and we do have pay parity laws in the state of Tennessee. So if we go payer by payer, commercial payers, Medicare Advantage payers, and things like that, we can set up some of those payments for pharmacists to see patients on their own, and they require a collaborative practice agreement. So that's one option for the fee-for-service side of it. General supervision means under the physician's overall direction, but you do not have to be under the same roof. So CCM and RPM are a great place to do that. If you wanted to share a position with other clinics, you can do this remotely. They could be doing it at home, or if the pharmacist has an office, they could do this for several different physician groups. Pharmacists in general are not doing anything that requires direct or personal supervision, but pharmacists can also bill Incident 2, and the requirements for Incident 2 are available at this link by ASHP, which is one of our professional organizations, and will be available to you in your packet of supplementary materials. So again, let's go back to the evidence of kind of what makes this work and what makes it hard. So the way that's defined in the evidence is, what are some of the barriers and facilitators of making it work? And I can kind of tell you a little bit about what I've seen. So barriers, there may be additional resources needed. So there may be patient handouts, there may be an office needed, there may be a waiting area for patients. There may be a lot of our office spaces are not set up for group classrooms, for instance, and things like that. There may be a lack of understanding or training in the purpose, like, for instance, quality or intervention of PharmD services. So a lot of times, if I didn't have a patient, I would try to make myself available to anyone and everyone to let them know I could help with dosing, I could help with interactions, I could help with PAs, because I wanted people to know what I was there to do. And I also wanted to get to know everybody in the front of the house, front desk, and that kind of thing, because patients would ask them about what I was doing there, what my services were. Not integrating well into the team. You're always going to have your early champions, hopefully, early adopters, and then you're going to have some that are skeptical or late adopters. And so if you already have a provider meeting or something in place where you can have that warm handoff and the champions introduce you to the team and let them know what it's going to be like, that is really, really good. And if you have limited leadership involvement, so for instance, on the TCMC group, if the CEO and CFO are not on board or ambivalent, it's going to be really hard for that person to integrate within the team, or it's going to be all on the clinical pharmacist to kind of make it work. But some of the facilitators are making early relationships, maybe even before they get there, with EHR or the IT team, because they may need a custom appointment type or template in the system, because they're not always generated in the larger groups. Very similar to what you probably heard in the health coaching presentation. Really early integration, research how to work with the payers. And again, this one may need to start before patients are being scheduled. The location of the services, we talked about that with the group classroom. Sometimes you can do those group classrooms at a community center, at a church, at a school, somewhere close to the clinic, but where everybody's comfortable, or at a different time of day. If your patients are still working who are doing the group classes, sometimes in the evenings or weekend mornings are what the patients want to be able to do. And then just the identification of people who are clinical pharmacy champions, because you're going to have some people that are saying, are they here to count pills? But you're also going to have people that say, I worked with pharmacists everywhere I've worked, and they were wonderful, like what we heard at the beginning of the presentation. All right, so now we have the group brainstorm. So what do you think are some of the biggest barriers or questions? What do you think are assets your team could use better? And how do you think we could help each other overcome the barriers? Some of the responses I have are forming very close relationships with the IT department as well as the billing department to make sure that the medical billing department, to make sure that the claims are submitted correctly. And there's not confusion that those are sent, or referred to the pharmacy billing, because that can be a completely different thing. Let's see what else. Financial constraints, hiring a whole new person. I think that for sure would be a constraint. And making sure that everyone is aware, that nobody's trying to take over anybody's team, that we're there to work with each other. I think that all of those are really, really great points. So, I'm going to talk to you about how to audit your practice for feasibility. And this is for the physicians. You have the opportunity to earn 1 extra hour of CE, and pharmacists are welcome to participate as well. But before you start going on this journey, I would say work with your EHR super user or your support staff and start looking at those high-level data numbers, like what I talked about a few slides ago. Look at your number of AWVs that are billed versus the number of Medicare beneficiaries. A lot of times I'll talk to clinics and they'll say, we're doing really well with annual wellness visits. But when you pull the numbers, it sometimes can be a lot less than what you think, or we're not billing for all of the ancillary codes that are available to us. Look at the current staff. What interests do they have that could be developed? So, for instance, I had a nurse practitioner when I first started that was really interested in diabetes, and she was sent for extra training, and she was able to take her board certification in diabetes. And we worked together and developed this kind of intensive diabetes workflow. And it really made a huge difference in our quality metrics. And that really makes a difference on retention of your nurse practitioners or PAs, because they're so invested in making a difference in the patient's lives where they are. What's the payer makeup of your practice? What does your space look like? I've had every kind of office you can think of. I've renovated closets. I've been here, there, and everywhere. What are the expectations of the practice? What's the culture like? The first practice I was in, it was very clear that I didn't make changes to the appointment calendar, whereas other practices, when I was doing account management, they were fine with it if we went in there and made appointments. So making sure all of that's very, very clear, because this person is in a new role. There's probably not a staff training notebook for pharmacists like there may be for nurses or lab techs. What are the resources for telehealth? How's the connection? How's the broadband in that area? And then what timeline are you looking at? This is another great resource for you. If you go into tnhearthealth.org, we have a pharmacist physician sustainability plan as a PDF that you can download and work from. It has lots of CPT codes, how you can partner, and that kind of thing. All right, and now it's time for you to paint your own picture. It's time to experiment. There's no 2 clinics that will look the same. I've definitely learned that. If you've learned one clinic, you've learned one health system, and that you've learned one. So every community will be different. And I think that is one of the things that is so exciting about how we can tailor it to specifically what our patients need and give them the best quality care. So now we will end with our questions to check for understanding. So which of the following would provide both revenue generation and quality metric potential as a clinical pharmacy service? So is it A, annual wellness visits, B, health literacy assessments, C, prior authorization assistance, or D, none of the above? So the answer is A, annual wellness visit. It looks like a lot of you got that right. So annual wellness visits is a fee-for-service revenue opportunity, and it also provides this opportunity to refer to other visits. Health literacy assessments can potentially be part of SDOH, but those are Z codes right now. And prior authorization assistance is not necessarily reimbursed. It could be part of CCM, and it certainly can help quality improvement. TCMC has decided to hire a clinical pharmacist. However, they need to decide on a clinical measure that could be positively impacting their revenue. Which of the following would meet that criteria? Is it A, 12 insulin prescription refills per calendar year, B, HDL below 30, C, antidepressant medication adherence, or D, calcium channel blocker adherence? Looks like C, antidepressant medication adherence. So that would be the one that is listed on our handout for quality metrics that pharmacists can impact. That will also be included in your packet. This is a list of our references. If you would like to meet and talk about your specific situation, clinic, as a pharmacist, you'd like to, or a physician, if you would like to network, please contact me. I have my cell phone number, my email address, my LinkedIn profile. Please connect with each other. I hope that you found this helpful. And I am happy to meet with any of you, talk with any of you about how we can better improve heart health and primary care in the state of Tennessee so that we can have better outcomes. So if you have any questions, please let me know. And I look forward to meeting you more and doing great work for Tennesseans. Thanks so much. Bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.